So, good day, sir. I am A.Reyes, your student nurse from Pamantasan ng Lungsod ng Marikina, and I will be demonstrating to you the respiratory assessment. But before that, I will explain first the rationale behind why we need to do this. So, the importance of respiratory assessment is to know the respiratory status of the patient and to get more information, to get more accurate diagnosis, and to work and plan together with the healthcare team. And then before entering the patient room, we need to always perform hand washing technique to prevent the spreading of microorganisms and to prevent the cross-contamination between me and my patient. And you need to always ensure the safety of your patient and then provide privacy for your patient. So assume that this room has a curtain, so you can close it to maintain the dignity of the patient. And then next is always do a body mechanics. So good day, sir. I am A.Reyes, your student nurse from Pamantasan ng Lungsod ng Marikina, and I will be assessing your respiratory. What is your name, sir?
I'm Noel Brigaudi, Senior.
And then, sir, just let me know if you feel uncomfortable. And do you want to go to the restroom first so that there's no disturbance or interruption during our assessment? Are you okay in this room? What do you think in the ventilation of this room? Is this alright to you? So, sir, I am about to start. Can you place your hand on your chest? So, after taking the respiratory rate of the patient, you can look for the symmetry of the chest and the movement of respiration of your patient. So, sir, you can now put your hands down. So, by the way, the respiratory rate of the patient is 18, so that is normal. And then look if there is a presence of spinal deformity and the respiratory effort, and then the skin condition of the patient. If the patient has any lesion like masses, moles, or body habitus. And then after inspecting the patient, we can now proceed in palpation. So I will be palpating your trachea. And after palpating the trachea, you can now proceed in palpating the chest of the patient, as well as the chest wall, to know if there is a masses or the tenderness is present on the chest of the patient. And then palpate the excursion of the patient. So place your hand on the chest of the patient and spread the fingers and place it in the costal margin of the chest. And then after excursion, So far, the patient's chest is symmetrical and no normal excursion. And after excursion, we can now proceed in chest tactile fremitus. So place your hand onto the chest of the patient, your hand bowl rather. And then after palpation, we can now proceed in percussion or percussing the chest of the patient. Percuss the anterior, posterior, and the lateral part of the patient. And note for the changes of the sound. And on the lateral. And on the other side to compare the sound. And on the posterior part. So after percussing the anterior, posterior, and the lateral part of the patient, you can now proceed in diaphragmatic excursion. So sir, can you deep breath? And mark the diaphragm. Sir, can you deep breath again? And hold. And exhale. So after using the marking pen to mark the diaphragm and compare it using by tape measure into a centimeter. So the measure of the diaphragm or the difference of this is 3.5 centimeter. And then after doing a percussion, we can now go to auscultation. So we will be using the stethoscope, and we will be listening to the full cycle of expiration and inspiration of the patient, and then note or just pay attention for the bronchioles, bronchovesicular, and the vesicular sound or part. And we will be listening to if there is any other sound on the top of the respiration of the patient, like crackles, wheezes, and then the stridor. So use the stethoscope directly to the skin of the patient. So because if there is any clothing up under the stethoscope, it can affect the sound of the respiration. And then we can now proceed to auscultating. First is the apex. It is located above the clavicle of the patient, which is the first intercostal, and then compare to the other side. And then next is the second intercostal, which is located at the beginning of the sternum. Next is the third intercostal, which is located between the sternum and the next is the fourth intercostal, which is the right lower lobe. Next is the fifth intercostal, and the sixth intercostal located at the mid-axillary of the patient. It is the lower lobe. And lastly, at the seventh intercostal. After auscultating the anterior part of the patient, you can now proceed on the posterior of the patient. So again, we will be starting at the apex part of the patient, which is C7. By the way, the C7 and to T3 is the upper lobe. The C7 is located above the clavicle of the patient. And then next is the T2. And then T3. And T4. So after auscultating the patient, you need to document all the findings. And so far in auscultation, I don't hear any crackles, wheezes, or stridor. So that's all. Thank you.